Hello everyone, this is Miss Gerald, and I'm going to be discussing perfusion. There are two parts to perfusion. There's part one, which I will be discussing in this voiced PowerPoint. Perfusion part two, we will be discussing face-to-face in class. So part one, we will be discussing atherosclerosis, arteriosclerosis, angina or angina, congestive heart failure, and pulmonary embolism. Those are the exemplars under the umbrella of the concept of perfusion. So CAD, coronary artery disease, is the leading cause of death in men and women in the USA. It may be asymptomatic, meaning you don't have any symptoms. You will have a patient who has no symptoms, or it can lead to angina or chest pain, acute coronary syndrome, ACS, MI, myocardial infarction, HF, heart failure, dysrhythmias, or sudden death. CAD can lead to sudden death. Many patients are living with CAD and they don't have any symptoms until it's too late, and then a patient suddenly dies, and it comes from coronary artery disease. But understand that the most common cause is atherosclerotic plaque. So it's a buildup of that plaque that's in the coronary arteries. Now there's a picture that shows your left and right main arteries. There's no testing on the blood flow and knowing these different arteries and where they're located. You learned that in anatomy and physiology and also 111. Now we are going on to talk about the concept of perfusion, these exemplars, how to care for patients who present to the hospital or even living in the community with these exemplars of perfusion. Okay, the most common cause, atherosclerotic plaque in the coronary arteries, most common cause of CAD. So I love this picture. It's giving you if you're a visual learner and you want to know what's going on inside of your patient's body who is experiencing atherosclerosis. That top picture there, see how the blood cells is free flowing, so you have adequate perfusion. Blood is free flowing. The middle picture there, it shows the plaque is building up. It's a buildup of plaque, and you see the blood is not flowing as freely, and you're having a backup of blood. The blood cannot get through with that plaque buildup. It's almost like a drain pipe. You know how your sink, you can tell there's a buildup of particles or hair in your drain pipe when the water stops flowing or it starts flowing slowly. That's the same thing that's going on there in the arteries with atherosclerosis. There's a buildup of plaque, so the blood is draining, is flowing slowly. Then the bottom picture is showing a complete occlusion and there's no perfusion. So you know, even at this point, what can happen if your body organs, your tissues are not perfusion with blood. If there's no adequate blood flow, what happens? It dies. Organs die, tissue die with no free flowing or no perfusion. Okay, so just keep that in mind, and then it helps you to be able to take care of patients or who have a decrease in blood flow and then who has occluded no blood flow, and you can know what happens. All right, so we just said atherosclerosis is a plaque formed due to the inflammatory response that's followed by collagen fibers that cover the inflamed area and it hardens. So that's what plaque is. Plaque forms when there's an inflammatory response that is followed by these collagen fibers that covers that inflamed area after the inflammatory response, and it hardens, so it forms that fat buildup, that plaque. And then your risk factors. We know total cholesterol should be below 200. So if you have patients with total cholesterol above 200, that's a risk factor for CAD. HDLs, if they have low good cholesterol, then that's a risk factor. It should be above 60 in men and women. If it's not, they don't have enough good cholesterol to help to move that plaque from the arteries so the blood can flow freely again. High LDLs are your bad cholesterol. If it's too high, then that's a risk factor. Your LDL should be below 130. If a patient has increased triglycerides, that's a risk factor. And then there's other risk factors: diabetes, obesity, a sedentary lifestyle, which means drug abuse, not exercising, couch potatoes, not eating right, smoking, of course, stress. Older adults are at risk. And then when you look at the cultural sense of it, African Americans and Hispanics are at risk. Now, look at the difference between arteriosclerosis and atherosclerosis. The first picture, there's a normal blood vessel. It's open, it's hollow, blood can easily flow through the vessels. Arteriosclerosis is when the muscle, the wall of the arteries of the vessels, they harden. They become very hard over time. It thickens. So when that happens, blood can't flow through as easily. The vessel is not hollow. Then arteriosclerosis, you can see that plaque, that fat building up, causing a decrease in perfusion. So when this happens in the body, think about what's happening. Your major vital organs are not perfusing, does not get the adequate blood supply. The tissues are not getting the adequate blood supply. Then we start having issues and problems, and we'll go into that. This is just a good way to remember what arteriosclerosis is. That's the hardening or the thickening of the arteries due to aging. When you think of arteriosclerosis, think of art. A man is old. Art, arteriosclerosis. Hardening, thickening of the artery due to aging. Atherosclerosis is when you have plaque that builds up, and know the risk factors that can cause that plaque to build up. Which of the following are abnormal values? And we just went through that. Those in red are abnormal. Your total cholesterol should be below 200. So if you see a cholesterol for 210, that's abnormal. Your LDLs, that bad cholesterol, is too high. You got too much bad cholesterol. It needs to be below 130. Your good cholesterol, the HDL, it needs to be 60 and above. So if you have a HDL of 30, that means your patients need to have, they don't have enough good cholesterol. We need to inform our patients to start eating healthier, start exercising, decrease stress, decrease those modifiable risk factors, start like stress, eating better, not smoking, not drinking, and doing drugs, and getting off the couch, not being a couch potato. So we need to have good cholesterol, the HDL. Okay, so just know you got to know your numbers. Okay, so let's think about dietary considerations. Again, now we're still talking about CAD in this point, but this can really, even though we're talking about CAD as an exemplar, it still falls under perfusion. So a lot of these you're going to see that even though we're talking about CAD, it can also talk about, it can help if we control risk factors. It can help with not only CAD, but it can help prevent MI, it can help with angina, it can help with hypertension. So a lot of these exemplars, that's why it falls under perfusion. If you can understand the whole concept of perfusion, you really can understand these exemplars with a few exceptions, and that's especially when we go into MI and heart failure, okay? So think about dietary considerations. This is one area that nursing students in particularly do not do as well or really need to improve on is understanding nutrition, because a huge part of nursing interventions is educating. We have to provide patient education. We are responsible as nurses to educate our patients and document that education. okay, because we want to improve the overall health of our patients. So low cholesterol, low saturated fats, we need to be teaching our patients this. Limit red meat, trim the fat, the extra fat that you see around meat, broil, bake instead of fried, low fat, dairy, spices, use like different spices, Mrs. Dash in the place of butter. Low sodium, again, you see I have hypertension there in parentheses because it's going to help hypertension as well as CAD. We need to increase our fiber, eat more beans, oats, fruits, vegetables, whole grains. We need to, when we think about sodium intake, think about the foods that are higher in sodium. We want to teach our patients to buy frozen or fresh vegetables and fruit and not canned because those tend to be higher in sodium. Processed foods tend to be higher in sodium. So we need to really understand our dietary considerations. You have an ATI book for nutrition. You really need to read that. There is also a chapter in your Saunders NCLEX review book, I think it's chapter 14, on nutrition. So yes, you will be tested on nutrition when it comes to perfusion because it is a way to minimize the modifiable risk factors, okay? Again, this slide just talks about which foods are healthy for the heart. What are healthy, heart healthy foods, okay? And they are listed in red. Just some examples, okay? Really go to your ATI nutrition book. NCLEX Saunders NCLEX review book, there's a chapter on nutrition to understand heart healthy foods, okay? Very important. All right, so let's talk about angina or angina. What is it? It's chest pain. It can be a temporary imbalance between the coronary arteries' ability to supply oxygen to the cardiac muscle and the cardiac muscle's demand for oxygen. So basically it's saying that your cardiac muscles is not getting the oxygen that it needs. It's a temporary imbalance of the ability to receive that oxygen, enough oxygen that it needs, okay? And if your heart muscle is not receiving adequate oxygen or blood flow, you can have chest pain. Now there's different types of angina. I'm going to focus on the chronic stable angina and the unstable, okay? So there are some patients that have chronic angina, but they're stable. This occurs whenever they are having any prolonged exertion, meaning they're exercising for a long period of time, or they're doing even just not even so much as exercising, but you may have some patients that they're participating in physical therapy in the home or physical therapy in the outpatient center or just working in their yard for long periods of time, and it causes them to have angina. This is usually relieved. It can be relieved with rest, and it can be relieved with nitroglycerin. The patient knows when it comes on. It's familiar to the patient. They know when their chest start feeling tight and they start having that chest pain, and they just need to take frequent rest periods, and we need to explain that to our patient. So if they're familiar with it, it can be treated with rest. It can be treated with nitroglycerin. It's the chronic, but it's stable angina. Okay, chronic stable chest pain. But then you have your unstable angina, and it occurs whenever. They can be just sitting there at rest, and it happens, or they can be doing some type of activity. So it occurs when the patient is at rest or when the patient is active. It lasts longer than 15 minutes. It may be relieved with rest or nitro. It may not be. So some patients, unfortunately, they do have the unstable angina, and we really have to be careful with these patients, and especially when we are assessing these patients, and when do we need to teach them what to do when they are not receiving relief from the angina, okay? And this is where we are teaching them about the nitroglycerin. You need to understand, I know you have been taught about nitroglycerin in your pharmacology class, but you really need to review Nitroglycerin is used, it's a vasodilator. It's used to open up or to dilate the coronary arteries to increase blood flow. Hence, if we increase blood flow, what are we increasing? We're getting more oxygen to the heart muscles. So we just said angina was due to a decrease or lack of oxygen to the heart muscles. So if we give the nitroglycerin, if we give patients nitro, it can help dilate those coronary arteries. They become larger, blood flows easier. It increases that blood flow, hence we can get more oxygen there to the heart muscle, and it can relieve that chest pain. Okay. Nitroglycerin comes in sublingual tablets, which we just have the patient to place under the tongue. It can be in PO. It can be in a transdermal ointment. And also, we can have patients on nitroglycerin IV. We have patients on nitroglycerin drips. And that's typically in your ICU or your step-down units, okay? So what is the patient teaching here? How many times or how often can nitroglycerin be given before notifying EMS? So how often do you want to give this patient nitroglycerin before activating EMS? So once a patient takes nitro, if they are having chest pain and they take one nitroglycerin under their tongue, if there is no relief after that first nitro, that patient needs to be taking another nitro in 5 minutes at the same time notifying EMS. They can take 3 nitros every 5 minutes, 3 times every 5 minutes, okay? Take a nitro, no relief. In 5 minutes, take another nitro, no relief. 5 minutes, take another nitro. After that third nitro, that's it. But after that patient takes that first nitro, if there is no relief, they need to, in 5 minutes, take another nitro, but at the same time, they need to be notifying EMS. Don't wait until all 3 nitros are taken because it could be too late. Okay, we need to be activating EMS or notifying even in the hospital setting. If your patient is having unrelieved chest pain after that first nitroglycerin, you need to be notifying the doctor or your rapid response team to make sure this patient has further evaluation, getting a fresh set of vital signs right away and notifying the doctor, okay, after that first nitro if it is unrelieved. So let's talk about the bad side effects from nitroglycerin, the normal and the bad. Normal, on the right-hand side, it will drop your blood pressure. Not only upon standing, but nitroglycerin will significantly drop a patient's blood pressure. So we need to think about safety with that. It will cause headaches. I already tell my patients when I'm going to give them nitro, now you may experience headaches. And I'll go ahead and be proactive if the doctor has ordered Tylenol for PRN for a headache or fever, or for pain, I'll go ahead and give that patient Tylenol because I know it is going to cause a headache. That's a normal side effect. I can anticipate that. It's not an adverse reaction. It's a normal anticipated side effect. It may cause them to have some numbness or tingling or feel nervous. So what do you think your most important nursing intervention would be with a patient taking nitroglycerin? You need to think safety, okay? The bad side effects, those are right there on the left-hand side. You can read those. And this is something that is a side effect, but I don't want this to happen. I don't want my patient to have that fast or pounding or a uneven, thready heart rate. I don't want them to have blurred vision, sweaty, throwing up, pale skin, feeling like they're going to pass out. That's bad. You need to understand the bad because I need to notify the doctor. But if it's normal, then like if a headache, I can give them Tylenol. If it's a drop in blood pressure, I can think safety, making sure I'm not educating the patient to rise from a sitting position very slowly. Make sure the patient, I have safety measures in place with the patient. If they're in the home, no scattered throw rugs in the home. If they're in the hospital, making sure, like I said, their environment is safe, call light and reach. Patient understands not to get up without assistance. Patient understands to rise slowly. If they have Tylenol ordered, I can go ahead and give them Tylenol for headache. Okay, it will cause a headache. I can remember, I'll share this with you. I was a fairly new nurse, and I was giving nitroglycerin, the ointment. Okay, it was a transdermal ointment I was placing on the patient's chest for chest pain, and I wasn't wearing gloves, and I got some nitro paste on my hand, a little bit on my hands, my fingers, and I promise you, I had a headache from that nitroglycerin paste because it's transdermal. It goes through the skin, and I felt a headache that I could barely finish the rest of my shift. So you know what it does to your patients. Okay, so we've already discussed CAD, and believe it or not, we've already discussed angina. What angina is, how to treat it, the difference between stable and unstable, nursing considerations or interventions revolved around the norm, and then if it's bad, those side effects there on the left-hand side for angina, when to notify the doctor, risk factors that are involved with CAD, nutrition, reviewing nutrition revolving around CAD, okay? Risk factors, modifiable versus non-modifiable, okay? We know the most common cause of CAD, all right? So let's move on. Now let's discuss CHF. Hint, I promise you, you know more than you are giving yourself credit for. You probably have already taken care of a patient with CHF already throughout your clinical rotation. You probably know someone personally with CHF. You know more about CHF than you give yourself credit for, okay? Don't make this harder than what it is. A general definition, what is CHF? It's basically when the heart fails to pump efficiently. It's not pumping like it needs to, okay? The heart fails to pump as an efficient pump. And there are reasons what cause this. There is no cure for CHF. It is a progressive, unfortunately, it's a progressive disorder, and it does worsen over time. So the main goal with CHF is it's basically just to manage the symptoms, because there's no cure for it. So we really need to teach our patients how to manage their symptoms, how to eat right, so we can slow that progression down. Not only how to eat right, how to take their medications right, how to improve cardiac function, how to control the fluid buildup, okay? Because there's no cure. So some risk factors. There's a list of them. There's a slew of risk factors that can cause CHF. So if we know there's no cure for it, we should try to prevent. There's some non-modifiable risk factors, but there's some modifiables. Look at smoking, substance abuse, obesity. We can modify that, okay? But read those, there's some that we can't modify. But if we have diabetes, think about that one. We can manage our diabetes by, again, nutrition, exercise, lifestyle changes, okay? So just think about that when we start thinking about congestive heart failure in your patient education, all right? Not going to read those for you. Those are simply listed, risk factors for CHF. So the most common cause is caused by hypertension, MI, dysfunction in the valves, the heart valves, and again CAD. It usually progresses from the left side of the heart to the right, okay? With the exception of right-sided heart failure may be independent. You can have a patient with right-sided heart failure, and it can be independent of left-sided heart failure, especially in your COPD patients. That's just an exception. So, preload and afterload. You're going to hear this term used. You may hear doctors using this term. You may see this on NCLEX questions, and then progressing in your nursing career, especially when you move up to level 2. Preload. What is preload? Preload increases. Preloads, it is the stretch of the muscle which is determined by the amount of blood returning, coming in from the venous system and the pulmonary system. So that's the preload. So just think about it. If you take a rubber band and or a slingshot, and you pull that slingshot back, it's like you are stretching that muscle. That slingshot or that rubber band is getting ready to force and pump that blood. So that's your preload. You're stretching it back. It's the amount of blood that's returning from the venous system and the pulmonary system. Preload. The pressure that the ventricles must overcome to pump the blood into the body. So you got preload and then you got afterload. So the preload is when the muscle is stretched by the amount of blood returning from the venous system and the pulmonary system. So just think about that slingshot. You're pushing it back. Then the afterload is you're going to let that slingshot go, or you're going to release that rubber band and it's going to go flying. That's the pressure from the ventricles that is pumping the blood into the body. Okay? So why might the heart may not be able to contract forcefully or enough to eject that blood? So you may not have, the muscles may not be as strong. The heart muscles may not be as strong, so you don't get enough preload. So if you don't have enough preload, then you're not going to have enough afterload. So just think if a rubber band does not stretch as far, it's not going to, when you release it, it's not going to go far. So just do that. Take a rubber band and stretch it as far as it'll go and then release it and see how the afterload, it goes far. That blood is going to go and reach all the places of the body that it needs to go. But if that preload is shortened, then that rubber band is not going to go far. Therefore, the blood is not going to pump where it needs to go in the body. That's a good scenario to just think about preload and afterload. So there's your answer. Increased vascular resistance due to hypertension. It can cause vasoconstriction. Again, if it's vasoconstriction, the blood is not going to flow. It's constricted. So the blood is not going to flow to the body where it needs to go. So these are some complications from CHF. I am not going to define these for you. Hepatomegaly, splenomegaly, impaired liver dysfunction, dysrhythmias, pleural effusion, pulmonary edema. Look these up. What does hepatomegaly mean? Splenomegaly. And I'm not going to test you on the definitions, but just know what complications, what's going on to your patient with CHF. They can have an enlarged liver. They can have pleural effusion, pulmonary edema, acute pulmonary edema at that. So look at what these definitions mean, and just means these are some complications that can happen to your patient because of CHF. And remember, it's no cure for it. It's a progressive disease. Now you can see why. Look at all the complications that happen from patients with CHF. That's really why we try to manage the symptoms and really do great patient education. You have to know the difference between left-sided and right-sided heart failure. You must. This is a cute picture that I received. I got off the internet from nursing education consultants. You have to know the difference between left-sided failure and right-sided heart failure. So just think left-sided. Why do you think, when you're looking at this picture, why do you think left-sided heart failure causes respiratory symptoms? If you understand the blood flow of the heart, then you can understand why left-sided failure, if the blood is backing up on the left side of the heart, it's left-sided failure, then why is this patient, you understand why this patient is having respiratory symptoms. They're having the crackles, the wet sounding cough, the wheezes, they can't sleep laying flat. They have to sleep up on pillows, the tachycardia, the restlessness, cyanosis, the blood-tinged sputum. We'll call these patients, they have frothy sputum, blood-tinged sputum. Left-sided heart failure, you have to understand the symptoms, okay? Because if you understand the symptoms of left-sided failure, then you understand how to take care of that patient and some nursing intervention. If a patient is having left-sided heart failure, you want to make sure that they are sleeping on maybe 2 or 3 pillows. You want to make sure they have Lasix on board because they have crackles and wheezes and that wet sounding cough to get rid of this this fluid. We want to make sure that we're controlling that heart rate, that we give them frequent rest periods, adequate oxygenation. We may have to give them some supplemental oxygen, respiratory treatments, okay? Now, right-sided heart failure caused by the left-sided failure, okay? Remember, we said it goes from left to right. So look at, you have some patients that basically that right ventricle is not emptying completely, so everything is like the traffic is just backing up, backing up. So if you understand the blood flow of the heart, you can understand why patients get swelling. Let's go to this next slide. Swelling in the extremities and in the abdomen area, the abdominal area, they get ascites because they have a buildup in the right-sided failure. Okay, from the left side, everything is backing up, so they get increased edema, swelling in the hands and the fingers, enlarged spleen, enlarged liver, ascites. They have complaints of GI distress because all that buildup is around in the midsection. They have JVD, that jugular vein distension. They're fatigued. You have to know the difference between right-sided and left-sided heart failure symptoms, okay? This is just a picture. I know we have seen some patients with edema, with the swelling, okay? Even if, and I'm sure most of you now have seen patients who have this or even personally know someone that suffers from edema. So if you have a patient with edema, we want to make sure that we are elevating the legs because we want to tell patients the importance of keeping their legs up as possible to try to reduce that swelling. We want to be measuring their abdominal girth, measuring the abdomen and make sure that their abdomen is not growing larger and larger, so we have to report this to the provider, okay? But I need you to understand right-sided versus left-sided heart failure and what nursing interventions to be done for both. That is straight out of your reading. Pitting edema, measuring pitting edema. I'm not going to test you on 1 plus, 2 plus, 3 plus, 4 plus, a trace of pitting edema, generalized edema, non-pitting versus pitting. I'm not going to go there with this, but just know what nursing intervention surrounds edema, okay? And understand the difference between left-sided and right-sided heart failure. So let's put it all together. Left-sided heart failure eventually will lead to hypoxia. It's no oxygen. Left-sided heart failure eventually will lead to hypoxia. Hypoxia causes the sensory nervous system to release epinephrine. Epinephrine causes the heart rate to go what? Increase. If your heart rate increases, that's tachycardia. That puts more stress on the heart. Then you have CO, carbon dioxide decreases, causes renal flow to decrease, then causes the kidneys to release angiotensin and renin response. Angiotensin causes vasoconstriction. So if you have vasoconstriction, you're not getting blood flow to your vital organs, your liver, your kidneys, okay? Aldosterone also secreted. And then aldosterone is secreted, then your sodium and your water is retaining. So then you have increase of fluid. We're talking heart failure, folks. It's a vicious cycle. You remember the saying, where salt goes, water goes, and vice versa. You got increase of sodium, water retention. Kidneys are causing a release of angiotensin response. Angiotensin causes vasoconstriction. You're not getting blood flow to your kidneys. The epinephrine causing your heart rate to increase. More stress on your heart. I'm telling you guys, heart failure is really, really taxing and hard on the patient. We have a high rate of hospital readmissions due to heart failure. That is one of the diagnosis that the Joint Commission is really trying to get a handle on and have core measures which are standardized gold standard measures across the nations, hospital to hospital, to try to get a handle on treating heart failure and keep these patients out of the hospital and let them be treated at home in their community with the education, patient education, and going back and forth to their doctor's office. Okay. We really see a repeat of hospital readmissions because of heart failure, unfortunately. So what do we do? What's the goal here? The main goals, we collaborate with other team members on the interdisciplinary healthcare team, the case managers, the physical therapists, the respiratory therapists. Our main goal is to slow the disease progression. Again, I said there's no cure for it, but we want to slow it down. We want to reduce the workload on the heart, reduce cardiac workload. We want to improve cardiac function. We have some patients that we will, the doctor will order for the patient to have cardiac rehab, where they go to outpatient physical therapy just to do cardiac, to do rehab on the heart muscles to try to make it stronger. Okay, and we want to, of course, control the fluid, the retention of fluid with our medications, our diuretics. I don't really need you to understand the different stages of heart failure. I'm not gonna, that's not testable material. There's no need to know the stages of heart failure, but know the main goals. How do we slow the disease progression? We educate this patient. We educate them on their lifestyle changes, no smoking, eating healthier, weight management, weighing themselves every day, the same the same time daily, the same amount of clothing first thing in the morning before they start eating and drinking. Tell patients, weigh yourself the first thing in the morning, same amount of clothing, which is typically what they wore to bed last night, not a lot of clothing. Report a weight gain of 2 pounds in one day or 5 pounds in 1 week. That needs to be reported to the provider. We want to slow this disease progression down. We want to manage it. Okay. Teach the patient to do light exercises to help improve cardiac function. Tell your patient to take frequent rest breaks. Okay, tell the patient to eat foods that are heart healthy and lower in sodium. Be careful of those canned foods or processed meats. Okay, that is the goal. That is your job as a future nurse. All right, moving on. So let's talk about medications. Yes, guys, you have to know your meds. This is a review. You're going to have to know your medications surrounding patients who are compromised with perfusion. Okay, you need to know your ACE inhibitors. You need to know not necessarily so much only by what they do, but you need to know example medications that are ACE inhibitors. What are some examples of ARBs? What are some examples of diuretics, beta blockers, nitroglycerins, cardiac glycosides, anticoagulants, antiplatelets? Main ones you're going to have to know: ACE inhibitors, ARBs, diuretics, beta blockers, nitrates, antidysrhythmic meds, anticoagulants, antiplatelets. Your main first line gold standard medications. That's pharmacology. That is a review. All of you have passed pharmacology, so you need to understand, know these meds, no side effects from them, nursing considerations, and any lab monitoring around these meds. This is what you've been doing on your steno pad, your note cards. You were not doing it for any just for the sake of doing it. Now you're getting ready to put it in practice, because I will have test questions surrounding medications, side effects, lab monitoring, and nursing considerations concerning meds that fall under ACE inhibitors, the drug classification of ACE inhibitors, diuretics, beta blockers, ARBs, antidysrhythmias, anticoagulants, antiplatelets. Okay? Again, we just basically talked about this slide, nutrition and activity. I'm not going to read that. I just basically said that the next two slides that was before this one: sodium restricted diet, fluid restriction, activity. Okay, so let's look at this question. A client has been taking furosemide or Lasix and valsartan, which is Diovon, for the past year. The hospital lab notifies the nurse that the client's potassium level is 6.2. What is the nurse's best action at this time? You got the best action, okay? At this moment that you're working on the floor, the lab calls you and tells you, the nurse, potassium level is 6.2. You know the patient has been taking Lasix and Diovon for the past year. What is the nurse's best action? So you need to understand what Lasix and Diovon does, right? You need to understand potassium level. That's abnormal. So you need to understand already. You need to know your labs, that potassium is abnormal. You need to know Diovon and Lasix. What is the best action given that information in that question? Are you going to assess the client's oxygen level? Are you going to ask the lab to repeat the potassium level because that's got to be a mistake? Are you going to give IV potassium? Or are you going to check the client's creatinine? All right, I hope you answered D. You're going to check the client's creatinine because taking Diovon will affect the patient's kidney function. Okay, they may not be excreting the potassium like they need to, even though they're on the Lasix. You know, Lasix is one of those potassium. It's not a potassium sparing, excuse me. It's a loop diuretic, so it gets rid of the potassium. So, but they're on the Diovon. Okay, so they may have a kidney function problem that's causing them not to excrete that potassium because that potassium is high. So of course you're not going to give them IV potassium. You're not going to do C. You're not going to have the lab to repeat the potassium. That's not the best action. Yeah, you may assess their oxygen level, okay, but the best action here is you want to make sure that you check that kidney function, which would be your creatinine. Okay, so you understand how you have to know your medications, and when I say no meds, no labs, and nursing considerations, you've been doing that all this time, so now it's time to put it into action. You did it on a steno pad, you're doing your note cards, your drug cards, now let's put it into action. Another NCLEX question, practice question. A nurse assesses a client admitted to the cardiac unit. Which statement by the client alerts the nurse that it's possible right-sided failure? I told you you need to know the different symptoms of right-sided and versus left-sided. I sleep on 4 pillows. Is that right or left side? My shoes fit too tight. That's the extremities, tight, edema, right or left side? I wake up with a cough every night. Is that right or left? I can't catch my breath. Right or left? And the answer here is B. My shoes fit too tight. That should let you know that's a possible right-sided failure because the edema and the swelling are in the extremities, the shoes. Their feet are tight, ankles are tight. Okay? Maybe if a patient says my pants are fitting tight or tighter now than they normally do, maybe that's right side because the abdominal girth, the abdomen is larger. Ascites, my pants don't fit as well. Okay? So you see how you had to understand the signs and symptoms to answer that question. All right, one last NCLEX question before we move on. A nurse is teaching a client with heart failure who has been prescribed Vasotac or enalapril. Which statement should the nurse include in this client's teaching? Do they avoid salt substitutes? Do they take their medication with food? Do they avoid using aspirin-containing products? Or do they check their pulse daily? I'm going to let you find that answer on your own, and you'll let me know in class. Okay? All right, moving on. Pulmonary embolism, PE. So how do we take care of a patient who have a perfusion problem due to a PE? What is a PE? It's a large embolus that blocks the pulmonary blood flow and is usually in the pulmonary artery. Okay? It reduces the oxygenation that a patient gets. It causes tissue to not get enough oxygen, so it causes pulmonary tissue hypoxia, and then it leads to death. Okay, PE is serious, folks. All right, here's some risk factors. Prolonged immobility. If you have patients who are not moving, you have your bedridden patients, they're not, that's the first thing we need to do when we have our patients in the hospital. They need to get up moving. We do not need to let patients lay around in a hospital bed. They are at risk for having a PE. Okay, central line, surgery. Huge risk factors with our patients, especially with hip and knee surgeries or there's orthopedic surgeries. We need to get these patients up and moving. Obesity, risk factor. Aging, history of thromboembolism, smoking, estrogen. We have patients who are younger patients or middle-aged patients who are on birth control pills. They will tell you you have a higher risk of PE. Heart failure, cancer, stroke, and other traumas, okay? But really focus in on the surgeries and their prolonged immobility, okay? PE. So what are your patients going to present with? What are the clinical manifestations? Some respiratory clinical manifestations. They're going to have a sudden dyspnea. I can't breathe, hard to breathe. Increased heart rate, tachycardia. They're restless. Guys, if you can't breathe or you have trouble breathing, your patients are going to get anxious, restless. They just feel of impending doom. They just feel like they're getting ready to die. Impending doom. That's what that means. Cough, hemoptysis, coughing up blood, crackles in the lung, even a low-grade fever. Okay? Could be some clinical manifestations for PE. Some cardiac manifestations, tachycardia, tachypnea, JVD, syncope, cyanosis. They're blue with the massive PE. Hypotension, pleuritic chest pain. The chest pain is through the pleural space there. Unilateral leg pain or limb pain. On one side their leg is swelling and they're having pain in that limb. Okay, could be a clinical sign of a PE. All right. You got to know your levels. I know I have not taught acid-base balance, and that's at the end, but just know some normal levels of ABG. This is just some diagnostic testing. The doctor will order an ABG to help confirm a PE. Not really going to go all into this now because we're really getting to acid-base balance and ABG interpretations, all of that later on. I just put this slide in here to let you know that the doctor will order a ABG as part of that diagnostic workup for patients with a suspected PE. That's all you need to know at this moment, okay? Not going to go into acid-base balance with you now on perfusion. Just know ABG is one of the diagnostic tests to work up PE. But the main gold standard of your imaging is the pulmonary angiography. Okay, this is the gold standard. This is what hospitals should be using. The main imaging test for a suspected PE is a pulmonary angiography. Okay, X-ray will show an embolus only if it's large enough. You may have a small one. That's why the gold standard is not an X-ray or even a chest CT, although you may see doctors order a chest CT, but that is the gold standard, is the first one there for a true definitive diagnosis for PE. So your high priority problems, you know, is hypoxemia. They can't breathe. Hypotension, risk for bleeding, and anxiety. So if you're going to put them in that order, it's ABC, right? Hypoxemia, hypotension, bleeding, anxiety. That is truly your ABC order. So the goal here, collaboration. Prevention is the primary goal. Prevention is the primary goal. You have to know as a nurse how to prevent a patient from getting a PE. Early ambulation, especially for our medical patients. Even if a patient coming to the hospital, I don't understand why we feel like a patient who was walkie-talkie at home, they come into the hospital, now they need to stay in the bed all the time. It is putting them at risk for a PE. Your surgical patients, especially your orthopedic patients, hip and knee patients, we need to make sure that our patients are wearing TED hose which are the compression hose, the pneumatic compression of the legs, which are your, what do they call them? SCDs, sequential compression devices. SCDs. If you have a patient in the hospital, this is one of my pet peeve. A doctor orders SCDs for a patient. Guess what? The nurse won't put them on. You'll find SCDs in the bed, but not on the patient. So the patient gets a PE. Who's liable? We need to be teaching our patients to elevate their legs. We need to encourage our patients to do active leg exercises. If our patients are bedridden, then we as the healthcare providers, as the nurses, need to do passive leg exercises. We can't rely on the physical therapist to do it. We can do passive range of motion. So prevention is a primary goal. Early ambulation, pneumatic compression of the legs, the TED hose, the SCDs, elevate the legs, active and passive range of motion, leg exercises. Then other supportive treatment, of course, your oxygen therapy. Okay, ABCs, oxygen therapy. Then we want to make sure this patient has pain medicine. We said they can have pleuritic chest pain. Give them medicine for anxiety. If you can't breathe, your patient is going to get anxious. Okay. Then we do ongoing monitoring of the cardiac assessment, monitoring the cardiac rhythms. I know we hadn't discussed dysrhythmias yet. I'm not going into that. You will get that later on. But assess cardiac output. Okay. So treatment, supportive treatment. Okay. All right, some other non-surgical treatment. They can do anticoagulant therapy. Typically, patients would be on heparin and Lovenox, heparin drips, or even the Lovenox sub-Q injections. Typically, it would be 5 to 10 days of heparin, then followed by warfarin or Coumadin on the 3rd day, but they will continue that heparin IV heparin drip, and then they would start taking the Coumadin while they're still on the heparin drip. And why is that? Why do you think that is? So they'll stay on that heparin drip until the therapeutic range for warfarin, that INR, reaches between 2.0 to 3.0. And I do have a slide in this PowerPoint that talks about the normal ranges. Okay? When a patient has a PE, the therapy continue until we want that INR to be between 2 and 3. Okay, so you may see patients on a heparin drip, and then they will start the Coumadin until that INR reaches a therapeutic range, and then the heparin drip is discontinued, and then the patient goes home on the Coumadin. Anticoagulant therapy. The fibrolytic medication, Activase, typically this was done in a emergency situation. It's really only in a critical situation, and that's to break up that clot. You will find that in the ER, the ICU, and it has to be given within a certain amount of time. I think it's within, oh my gosh, I forgot. I'm going to have to look that up and get back with you, the time frame. I want to say 4 hours, but my mind just went blank. But typically that's what the Activase does. It's a clot buster. That's what we call it. These are your labs. You have to know your labs that you have to monitor with your anticoagulant therapy. Heparin, you're going to monitor the PTT or the APTT. So you will monitor the partial thromboplastin time or the APTT, the activated partial thromboplastin time. You're going to monitor your platelets, and then you need to know the antidote for heparin. If you have a patient that's on a heparin drip and they're getting too much heparin and their blood starts thinning out and they're having abnormal bleeding through the ears, the nose, the gums, bloody stools, the urine, you need to make sure you notify the doctor, stop the heparin drip, and anticipate that the doctor is going to give protamine sulfate. That's the antidote for heparin. Lovenox, you're going to monitor the platelets. You need to know the antidote for Lovenox. You need to know warfarin or Coumadin. We're going to monitor the INR, and the antidote for warfarin is vitamin K. Nutrition fact. Patients who are getting Coumadin, remember, we need to make sure that they are not eating foods that are high in vitamin K. because it's going to interfere or counteract with the warfarin, and that NUR would never reach the therapeutic between 2 and 3. So patients that are eating, we want to tell our patients not to stop eating those foods that are high in vitamin K, but to limit them, meaning your green leafy vegetables. Limit those dark green leafy vegetables like your kale, your collards, your broccoli, your mustard greens, and then limit those intake of the dark green leafy vegetables because they're higher in vitamin K. Okay? Nutrition fact. And there's your therapeutic levels that I was talking about, the PTT, PT, and INR. All right, NCLEX time. NCLEX question. While assessing a client who has been receiving heparin IV for the past 3 days, the nurse notices that the pump is set at twice the required settings. Wow, so the heparin was ordered at one rate, but then now the nurses knows that the pump is set at a higher rate, 2 times the amount that it was ordered. What does the nurse anticipate the doctor to do? Select all that apply. A, B, C, D, E. And that one is another question. I want you to find the answer, and we will talk about it in class. Okay? A good NCLEX question. PE. Also, you can have some surgical management, embolectomy, where they will actually go in, the surgeon will go in and remove the blood clot. And also, you can have a inferior vena cava filter that prevents that it traps that clot. It prevents the emboli from reaching the pulmonary artery, which can cause death. So you probably have heard this called a green filter. It's a filter that is put in place in the inferior vena cava. It's a filtration system, and it blocks that emboli. It stops it from reaching the pulmonary artery. That's a some surgical management. Okay. All right, if a patient is having a PE, guys, I'm telling you, it is an emergency. If you notice syncope, blue, there's cyanotic, hypotension, sharp pleuritic, chest pain, vein distension, you need to notify rapid response, okay? Get a fresh set of vitamins, get a fresh set of vitals, get some oxygen on that patient, sit that patient up in a high Fowler's or Fowler's position, notify rapid response, okay? If you suspect a PE. So which of the following should be avoided if a patient is on anticoagulant therapy? Okay? And it's those in red. You don't want to use a large bore needle for patients on anticoagulant therapy because they're already at risk for bleeding. So use like a typical 20 or 22 gauge IV needle, not a 18 gauge, or because they're already at risk for bleeding. You want to avoid enemas, administer enemas to avoid constipation, and we want to floss our teeth thoroughly to avoid gum infection. This is what we want to avoid, okay? We don't want to give enemas. We don't want to be flossing our teeth as thoroughly because we don't want they're already at risk for bleeding and bleeding gums. Yes, they still need to have good mouth care, but not to be flossing really hard. Another thing, we don't want to make sure our patients are not using razors because if they nip themselves, they could bleed out. So we want to let them use electric razors or electric shavers, not razors, electric shavers, not razors. Okay? So just know that it's good information, but this is also can be formed into a good NCLEX question. All right. All right. This last slide is telling you that there is a case study on Moodle that you have to complete for CAD and CHF. Go ahead and complete this case study. We will be reviewing this case study in class. Make sure, I did not put this in a PowerPoint, but you have to make sure you know how to care plan a patient with perfusion problems, particularly CAD, angina, heart failure, pulmonary embolism. It is straight in your Pearson book. I love the way Pearson lays out the nursing process. You have to know how to care plan patients with these exemplars, okay? Always include teaching as a part of your implementation. A lot of those exemplars, it really rely on teaching, prevention, okay? Pulmonary embolism, heart failure, CAD, prevention, okay? Angina, teaching. You have to teach this patient the right way, how to take nitro, what are some normal side effects. So always include teaching, okay? That's patient-centered care. Always know how to evaluate the effectiveness of patient care if those goals have been met. So if you have a patient with CHF and the goal is to improve edema, how do you evaluate if the edema is improved? Or if you have a patient that you want to improve the cardiac output, how do you evaluate cardiac output has been improved? You can evaluate the vital signs. They have stable blood pressure, heart rate. They have the adequate urine output. That's how you know that the kidneys are being perfused, because they have adequate urine output. So you need to understand, how do I evaluate that the care that I'm providing for the patient and that the goals are being met, that the care is effective and the goals are being met with perfusion. Okay, so think about that when you're doing nursing process. We will do nursing process in class, and we will do case study in class around the patients with perfusion complications. Okay, all right, that is it for part 1. If you have any questions, please do not hesitate to email me. Thank you.